Welcome to another episode of Clean Talk, the Infection Control podcast. I'm your host, Brad Whitchurch. We are coming to you live from beautiful downtown sunny Orlando, Florida, here in the sealshield studios. And our guest today on Clean Talk is not Bill Nye, the science guy. Even better, it's Christian Davis, the science guy. Christian's an engineer with a background in computer science and biomed. He is a CIO of the year from the Business Journal here in Florida. And in his current role, he's Chief Technology Officer at sealshield. Christian, welcome to the show.
Hey, thanks, Brad.
Well, Christian, what more can you tell us about yourself and why you're on Clean Talk today?
So I'm on Clean Talk today. Well, first, I'll start a little bit, about myself. So as Brad mentioned, I'm the Senior Vice President of Technology and Product Development at sealshield. I am the acting CTO. And at sealshield, what we focus on is developing and utilizing technology and applying technology in a way to make measurable impacts and favorable outcomes in infection control. So I think high level, that's a good gist of what we do.
Well, that's fantastic. I appreciate you being on the show today, Christian. I know you're also a certified infection preventionist, and this is the show all about infection prevention. Last week on our show, we had Dr. Chad Roy, and he talked about how every day we're exposed to hundreds of thousands of organic organisms, but only a few of them are pathogenic. We know that during COVID, hospital-acquired infections have been on the rise, and we're familiar with a lot of the superbugs that are in hospitals. We hear a lot about C. diff and MRSA, but Christian, you're here today to talk about something that's been emerging as a superbug in the hospital systems. Tell us about Candida.
Yeah, so Candida auris, while maybe not one of the most talked about pathogens in the healthcare system, probably most notably because it's a new emerging pathogen, has really taken the stage starting back in 2016, right? So in 2016, we had roughly about 5 states with clinical cases here in the US. And you fast forward today, now we have over 20 states with clinical cases here in the US. And of those 20 states, we have roughly 4 of them with over an active 101 cases with Candida auris. So something that really wasn't spoke of, really wasn't on the map, has appeared. It's taken root. And not only has it taken root in the US, as of February 21 this year, they stopped reporting actively country by country because it had become global. So we had seen enough cases from enough emerging and developing countries that at this point it is a global pathogen.
Well, tell us a little bit about Candida, because most of the pathogens that we're familiar with are bacterial or virus, but Candida is a fungus or maybe technically a yeast. What more can you tell us about that? And how do you typically treat those kind of pathogens?
Yeah, correct. So, one of the biggies that we've obviously spoke about and we've developed technologies around at sealshield for many years is, and most publicly well-known, we MRSA, right? So to delineate, that's a bacteria, right? And it's a bacteria that is a methicillin-resistant Staphylococcus aureus, right? So we created this by the overusage of broad-spectrum antibiotics, and that's how we would treat bacteria. However, with Candida auris being a fungi and specifically a yeast, that would need to be treated with an antifungal. And there are species of Candida auris that are completely drug resistant at this time. So that leaves us with a lot of options to where we want to really prevent and mitigate this pathogen being in the environment so that we do not end up with a clinical case, a colonization, and then potentially, an infection.
And if it's a superbug, does that mean it can't be killed? Talk a little bit about that and what are the possible remedies for Candida or other superbugs, bacterial or viral?
Yeah, I think that's really where sealshield comes into play. I think our greatest effort to be able to reduce, these superbugs, as you call them, in the environment is literally that, is infection control practices to where we're focused on the environment. If we're waiting till the time in which we have an active case or we have an infection, we're already behind the eight ball at that point. So what are we doing in our environments within healthcare specifically, right? So we find Candida auris specifically within healthcare settings, long-term care facilities. We've seen the spike in it primarily because patients that are on ventilators, that is atypically a scenario to where you're going to see more cases. So through COVID, a lot of active ventilators, long-term care facilities, a perfect recipe. So if we're not working in the environment and working on the environment, we're then becoming reactive. We want to be proactive. And SealShield really takes an infection control approach of being proactive, not reactive.
I want to go back to something you mentioned before. You mentioned MRSA. A lot of people are familiar with MRSA. It is, of course, a staph infection that is resistant to antibiotics. And you made the comment that we created MRSA. Explain that a little bit more. What do you mean by that? Because we didn't create it on purpose, right?
Yeah.
How did these superbugs emerge in healthcare settings? Talk a little bit about that.
So that goes back to my comment of dealing with a reaction versus being proactive, right? So when we're reactive, we're dealing with infections with drugs, with broad spectrum antibiotics, right? And so when we talk about certain pathogens, for instance, like MRSA, MRSA is not just MRSA. There are multiple strands of MRSA. There are multiple sensitivities. When we say sensitivities, that means that in one case, MRSA may have a sensitivity to like clindamycin. In other cases, it may not have a sensitivity to clindamycin. Did MRSA come from the public or did it come from a healthcare setting? All of these variables, it is not straightforward.
But it's like you said, it's because we've had a reactive approach and we have been spoiled because of the miracle of antibiotics. And that was an easy solution that took care of most of our problems for a long time. But now in the healthcare setting, as you mentioned, with the widespread use of broad spectrum antibiotics, it's created resistance in some pathogens that are actually, as you said, being created within the healthcare environment because you've got an environment that is ripe for that type of pathogen to develop as it develops resistance to the widespread use of antibiotics. But now when we talk about Candida, antibiotics aren't a solution for fungal pathogens, right?
That's right. Yeah. So antifungals, right? So if you look, the development on antibiotics, there really hasn't been a lot of new development in antibiotics. And quite frankly, you get to the end of the road with something like a Zyvox. If you have a particular bacteria that's not responsive to that, well, you're at the end of the road, right? It could be doom or gloom. So with the antifungals, again, not a lot of development, not a lot of new releases. And right now there's not an antifungal that is super effective for the resistant species of Candida auris. So given, the right infection or clinical case, that could be unfortunately, doom for someone.
And how can we prevent the spread of something like Candida? What are some solutions to these pathogens in the healthcare setting?
So some of the solutions would be focusing on our environment, right? So if we look at in healthcare, we have practices, and along with practices, we have policies. So policies may be very well written and articulated for certain devices, but then you have other devices in healthcare, right? Healthcare has had a lot of change over the last decade with the emergence of EMRs, our electronic medical record systems, which has brought in a lot of wonderful technology that has the ability to change patient outcomes and change patient engagement. However, they're all new variables. Those new variables are, now we're bringing peripherals. In the old days, maybe we had two peripherals. Maybe we had a keyboard and a mouse at a nurse's station where we began. And now today we have 30 or 40 devices that are all mobile. They're moving in and out of patient rooms from patient to patient. And what practice or what policy is surrounding those devices? And the real risk is we thought keyboards and mice were bad, right? Keyboards and mice weren't actively 10 years ago going in and out of the patient rooms. Now we have devices that are going in and out of the patient room, and they're coming within, bedside distances.
And so these are cross-contamination vectors, right?
Absolutely.
So you have equipment that's going to places where people are infected. Those pathogens can then travel this equipment to other locations and
Correct.
spread throughout the facility. So talk about how clinical informatics plays a role today in infection control to make sure these devices are appropriately disinfected so that you're not spreading cross-contamination infections. Can you talk a little bit about clinical
Sure.
informatics?
Yeah. So clinical informatics is obviously emerging in healthcare. A lot of times,
First of all, what is it? Explain to people
yeah.
what do we mean by clinical informatics?
So I'll tell you how I view clinical informatics, and I think someone in that field may have a different perspective, and that's fine. But typically, in our customers, when we are speaking to clinical informatics or people that work in that field, they are usually a registered nurse or have training, in the nursing field, and had a tendency towards technology. And like I said, as these EMRs have emerged and technology has merged into healthcare, it's really required someone to kind of bridge that gap between just a pure nurse, a clinician, and a technologist, right? So how do I leverage these technologies and integrate them into the workflow of how do I do my patient roundings more effective with the technology within my hand? So they're touching all of the data that surrounds patient engagement from a nursing perspective. That's how I see or I see individuals that work within clinical informatics. So, they really see both sides of the house. They see what technology we're using, why are we using it, and for what.
So typically, you wouldn't think of someone who's in clinical informatics as necessarily having a crucial infection prevention role. Is that right? And is that changing?
Sure. I think so. I think historically, right, it was all about clinical workflows, patient roundings, how we're using data, how we're using that data to improve our patient outcomes, et cetera, right? But they start to bring in new appliances, right? The technology to do these workflows to drive efficiencies. And when they do, there comes the new variables, right? So now they have to think about, wow, okay, yes, we have this mobile device that we're using, on patient roundings to bring into patient rooms. How could this be contributing to potentially an infection with that patient? So on one aspect, maybe, they're hoping to improve that outcome, while on the other side of the fence, they're bringing in a new variable that potentially is offsetting that advancement in technology. So technology is a double-edged sword in this case, right? So they've got to look at it from both sides now.
So, give us some examples of maybe some emerging vectors for cross contamination as a result of the development of tools that are integrated with the healthcare EMR systems. Where are there problems, and what can we do about it?
Yeah, when defining and identifying vectors, I think there are many, right? So I think we have to take a broader approach and say anything that is a handheld electronic, whether it's a scanner, whether it's a phone, it is a PDA, any device that is allowing them to automate their patient workflow that's going in and out of patient rooms, those are your risk, right? Because again, those are going to be devices that don't necessarily have a compliance policy, but probably should have a practice. So the question is, what are the practices and how are they measuring and ensuring that those practices are being followed?
Are there standards around these practices and policies? I know we like to talk about best practices, but are there any standards that are developed that are really becoming instrumental in dealing with these new potential cross-contamination vectors of these devices in healthcare?
On all devices, no. I think a select few, yes. You do have some medical devices, obviously, because of their IFUs, and if a hospital is following their IFU based upon that device's 510(k) registration, then clearly, there's something that the Joint Commission would measure them on. Are they being compliant? Right. But then there's a lot of new devices like handhelds, specifically PDAs, that do not have IFUs that are being monitored by the Joint Commission. So therefore, a hospital must think, well, we should probably have a practice. We probably should have a way to clean this, but not necessarily a regulatory body that is measuring it real time.
And tell our audience, what's an IFU?
Instruction for use.
Okay, great. So let's take the example of a cell phone, which is a device we're all familiar with and has become really a critical device in the workflows in healthcare today. I know the CDC has come out with some guidelines around how to clean and protect those devices. What can you tell us about that?
Yeah. So when I think about a cell phone, you really think, how can it be classified, right? So the way it could be classified now, logically, would be a non-critical medical device. And what the CDC would make us a recommendation on, right? In the CDC isolation guideline, which is the handbook for how hospitals should clean equipment within healthcare based upon its classification. They would recommend that it be cleaned in between each use, very broadly. So at a minimum once a day, and at most between each use. Again, a recommendation. So those are recommendations that hospitals should be heeding, which most of them are, and then putting it into a practice. And when we say practice, to clarify, practice is more like in another industry, an SOP, right? It's their standard operating procedure for how they deal with a particular piece of technology, information, et cetera.
So, in the case of the cell phone, first of all, can Candida be transmitted via hard surfaces, or is it do you know, is it a bronchial, airborne, or can we have cross contamination through these type of devices for something specifically like Candida?
So I think the culturing procedures that are in place right now through the CDC to detect this when it's in the environment, especially when they have a clinical case, I think it's a little bit too early to say for certain what are all the contributors. But the fact that it is being cultured from surfaces would suggest if it's on a surface, it could be on one to many surfaces, so all surfaces at that point become suspect.
So, is it good enough to have a thorough cleaning process? When you talk about the cell phone, I know the CDC came out with, and correct me if I'm wrong, I think it's 5 wipes to 1 high level disinfection. You can correct me on that if I'm
Yeah,
wrong, but is
low
that
level, but yeah.
low level
Yeah.
disinfection? So, is wiping down these surfaces sufficient? Do we just need to do a better job of cleaning our environment? Is that the solution?
We don't think so.
Okay.
We don't think so for a couple of probably pretty logical reasons. Most notably, with cleaning surfaces, it's highly variable, right? And so typically when you look in hospitals, the individuals that are cleaning the hospitals are the least technical within the entire facility. And so you have a lot of variability with cleaning with the EVS groups within hospitals. So it is not a standardized approach. It's very non-standardized. So a lot of times maybe cleaning results in just moving pathogens from point A to point B, especially because of things like dwell time. Dwell time really, are a risk and an issue with today's cleaning, protocols and practices.
So explain to our audience what dwell time is.
So a lot of the active disinfectants in healthcare, in order for them to achieve efficacy on a specific organism, they have mandatory dwell times that get you to that log reduction. So if that particular disinfectant doesn't remain wet or in a wet state over that surface, you can assume that you actually have achieved the disinfection or the efficacy capability of that disinfectant per that particular organism. So.
And a lot of these healthcare grade disinfecting solutions can be fairly caustic to hard to clean devices, right? So it may be appropriate for the tabletops and the floors, but might have some adverse effects on some critical medical equipment. What is the solution?
Yeah, that's correct. So when you look at the manufacturers of these devices, their IFUs, right, their instructions for use and their cleaning guidelines really don't open you up a lot of times to a disinfectant that the hospital is standardized on in a department, right, to give them a good broad spectrum. If they're dealing with C. diff on a floor, they're dealing with a Candida auris, or they're dealing with MRSA or VRE, the list goes on and on. A lot of times, most of the times, the manufacturer's IFUs don't allow for those chemicals, especially the dwell time, to come in contact with that device. Therefore, you're looking at other technologies like UV, which is highly effective across a broad spectrum of organisms. And with UV, you can actually take a standardized approach. So you even have a leg up. You can be broad spectrum while at the same time having a standardized approach to disinfecting the organisms that have concern for us.
So we talk a lot about UV light on this show, and specifically UVC. We know that we've seen equipment that's been damaged by chemical cleaners in the hospital system. Now, UV can be damaging as well if it's not used appropriately. Is UV an effective solution against Candida?
at this time, the data would suggest yes. I think more research is needed, but based upon some testing with surrogates, it would suggest that it would be effective. This is kind of the same scenario early on when we were looking at SARS-CoV-2.
Right.
We didn't have data right away with UV to suggest that for a fact we had efficacy, but we had surrogates that we certainly could say, well, based upon the reaction of that surrogate UV, we believe that it would be effective on SARS-CoV-2. Now the research has been published in peer review, and in fact, we know that UVC is highly effective against SARS-CoV-2.
So effective cleaning protocols to overcome the overuse of broad spectrum antibiotics, cleaning protocols that utilize EPA grade disinfectants and potentially UV light. What else do you see as opportunities to help solve this problem of hospital acquired infections? What should we be doing, or what could we do better?
So there's multiple technologies that are changing always. That's the wonderful world I get to live in, is the rapid change in technology and how we apply it. But whether it's UV that's helping us standardize, UV in some cases is a great whole room application. In other cases, it's really not. Dry fog with hydrogen peroxide vapors, highly effective, but sometimes not the most effective from a time standpoint. And hospitals are focused on how quickly they can turn, patient beds. So there's a lot of great technologies out there, but I really think it is understanding how we can take the best of the technologies available to us today, apply it in such a manner that minimizes the time, right, between patient rooms, standardizes the disinfection process to ensure that we've got, the clean room from all aspects, and remove that variability which exists today. Now, most of all these technologies still don't replace cleaning. So cleaning still will go on, right? UV doesn't replace cleaning. Actually, it augments, right? So I think there's no silver bullet. I don't think there ever will be. But I think there will be a blend with technologies, as long as we can extract data from all these events and make sense of what's being used and how effective it is. So what is the data? How do we measure it?
Let's talk about that data, because we have lots of pathogens. There's lots of solutions depending on the application, depending on the pathogen. But how do you know if this is working? And with so many vectors and so many pathogens, how can you manage an effective protocol? It's the data, right? How can we utilize data to have better outcomes from an infection control standpoint? And how's that being done today?
Sure. I think, like all businesses, eventually we learned that we can't manage the business in today's time without data. Infection control is no different, right? So being able to measure, as an example, if we're leveraging UV for an active disinfection in a given area, did it actually occur? Did it occur for the amount of length that we know to be required scientifically to reach the efficacy that we're shooting for, and within that particular room where the right dosage is received? You've got to be able to measure that. And how do you measure it if you don't collect data on that event, right? So there are a lot of applications that still need to be refined with that collection of data with these technologies, so that hospitals could really look across the board and say, we've got a 3-pillar approach to disinfecting, a given area. And here's all the data that we've collected from those 3 events to know 2 things. They happened, they were effective, and we can be rest assured that the room is clean and we're minimizing impact to our patients.
Right. And so it's not good enough to have the device or the environment cleaned if you can't prove it, right? So you have to have the data to show that it's been done. And in healthcare systems, they need this data to potentially pass a JCO audit. Is that correct?
Correct. I mean, absolutely. If we're talking about devices, again, that where they're having to follow an IFU because of that device's 510K registration, they've got to have a policy in place, and then they got to prove that they're adhering and abiding to that policy, right? So it also depends on how well they define that policy, but they have to prove that the policy is being followed and adhered to, for sure.
Well, so Christian, I know you're a product development guy. I know you very well. You're kind of the Willy Wonka of infection control. I'm going to put you on the spot here. What do you see for the future of infection control and development and innovation towards improving patient outcomes through infection prevention?
I think no different than what we've seen in all industries. I think we're going to see an aggregation event of data to where data from multiple aspects of infection control are coming to a central platform and repository that's given us the insights and the ability to predict and do analysis to improve. I think it's always a continuing improvement process. And how in the world do you continue to improve if you don't have the data historically to look back to say, where have we been, where are we going, and what's our issue at the moment?
Right. Well, there's a lot of technology out there, a lot of effective technology, but using it in the right methods and then being able to measure it and track that is key. I see for the future of infection prevention, the utilization of technology that exists today, pathogen detection, automation, robotics, self-disinfecting. We should, through the data piece, be able to actually track the spread of these infections with the aggregation of technology that largely exists today. Would you agree with that?
I would agree. Absolutely. Yeah.
Yeah. So I think that's really, from my perspective, where we're going. The future of infection control is being able to have pathogen detection, automatic eradication, using robotics and the data to be able to track those vectors of infection real time so that you can break that chain of cross contamination before it spreads. And we're not that far away with the technology we have today. We just need the standards and making sure that all of these different methods are talking to each other.
Correct.
So you are the key developer around the sealshield electroclave, which is our UVC disinfection box. One of the key attributes of that device is its intelligence. It has RFID tracking, so it's tracking every single cell phone or device that is disinfected through that. And then what can a healthcare system use that data for? What do they do with that data? How are they utilizing the data? Because it's one thing to use UVC disinfection, but then why is the extra data piece so critical in that specific example?
The best analogy I could give you is why would you spend the additional money on a wonderful new wheel, the electroclave, right? It's a new wheel. It's a new way of disinfecting a device. There could be many ways of a handheld electronic. Why would you spend the money, the additional money on a solution like that if you could not measure to ensure that was getting done? Because then I would say there'd be no difference between a wipe or the electroclave. The big difference is with one, you can buy and hope, right? And the other, you can buy and know. And with the electroclave, it's the latter, right? So they can put these solutions in place, have a practice in place about what they're doing with their handhelds, ensuring that they're getting disinfected. And most importantly, when they're not getting disinfected, the solution's actually taking actions for them without requiring additional time or resources from the organization to ensure that these devices that we're worried about from a cross-contamination standpoint are being disinfected and disinfected regularly.
So we all know that hand washing is a key defense against the spread of pathogens. And we know that hospitals that successfully drive their hand washing initiatives do see results from that. But what would you say to a healthcare system that is focused on an investment in hand hygiene and is not addressing some of these mobile devices from a device disinfection standpoint? What would you say to that?
I would say I couldn't agree more that hand hygiene is probably our first and probably greatest practice to put in place to prevent the spread of or the event of an infection. However, like you mentioned, even with the best hand hygiene practice or policy in place, if you only washed everyone's left hand, how effective would that hand hygiene, policy and procedure be? It would be non-effective. So if you think about handhelds and the way in which individuals, even outside of healthcare, just in general, we touch our devices multiple times a day. And so if we have a great hand hygiene protocol, yet we really don't have a sound practice to ensure that devices that we know come in direct contact with the hand that are known to carry pathogens, if we're not cleaning those and when we don't have the information and the intel to know it's being cleaned, we're really minimizing our already, we're reducing our investment and our ROI in hand hygiene by not addressing the full picture. You're addressing half of the picture.
So healthcare systems and others spend a lot of money, a lot of resources on hand hygiene, whether it's hand sanitizer, more hand washing stations, more soap. But if they're making that investment and they're not investing in cleaning protocols or disinfection protocols for the items we touch, what does that result in? That's what you're saying, that there's a reduction in ROI for the investment you're making in hand hygiene,
Yeah,
because you're not addressing the broader issue, right?
you've negated your hand hygiene at that moment. These devices are just touched too frequently to not have a equal investment in ensuring that the devices are free of pathogens. But there's multiple peer reviews that have been studied and published to look at phones and PDAs and scanners and all of these portable handheld electronics in healthcare. And, they have been known to carry a lot of the superbugs we spoke of early. So, if we're not treating and disinfecting and dealing with those devices, we're really just delaying the inevitable.
So do we know for certain that a pathogen on a device like a mobile phone can be transmitted to a person's hand and then transmitted from there? Is there evidence to that?
Yeah, multiple peer reviews. It's actually astounding the amount of research that's been done in this area going back to 2012, right? That's when we started to see the first surgence of mobility into healthcare. And there's been many peer reviews that have suggested with just one touch of a phone, looking at a clinician, simply asking them to pick up the phone as if they were to answer a call or to take a call, and then remeasuring their clean hands after that one touch with that device, you find a transfer from whatever was on that device directly to the hand. So yeah, it's been proven, and we see it through peer review multiple times, not just one outlier.
Well, Christian, is there anything else you'd like to share with our audience today? I know you're an expert in infection control, and a lot of people in the audience, don't have the kind of exposure to the healthcare systems that you do and have access to the technology that you do. Is there anything else you'd like to share with our audience in closing?
It sounds like I've got a busy roadmap, which we love. So I guess continue to look at our innovation and how we're continuing to leverage technology in the best application. We truly believe it's not about the technology, it's about how you apply it. So more to come, a lot of good innovations in the near future.
Well, thank you, Christian. So we're all living in the COVID world, but we have other things to worry about. Keep your eyes on Candida, and hopefully we can address the Candida as well as other superbugs through innovative infection control processes and procedures and solutions. We've got new pathogens. We've got new technology to address them. We have new technology that we have to address around pathogens. And in order for it to all be successful, it has to be data-driven for improved outcome for healthcare patients and practitioners.
Agreed.
Fantastic. Well, Christian, thank you so much for being on Clean Talk today. You've been watching Clean Talk. I'm your host, Brad Whitchurch, reminding you until next time, keep it clean.